Hey, welcome everyone. Please drop your questions into the chat. Let me get the music off for you. There we go. So, welcome everyone to Level Headed Mind. Today, we're going to be I'm going to be answering questions for any questions about mental health. We're going to go from 11 a.m. Eastern Standard Time now till 1 p.m., so 2 hours. And again, that's Eastern Standard Time. So, we'll go in order as the questions are coming in. And if the questions get backed up, we'll do priorities is always for channel members, and super chats get priority answers to questions as well. Okay, so let me see if we have any questions and get this banner off of here. Okay. Hi, Ephraim. Hello, I've degree in psychology and planning to study PMHNP, which is psych mental health nurse practitioner, which is what I am. How many total years does it take before I start working? I'm not sure how your credits will transfer into the master's program for psychiatric nurse practitioner. Um, for me, after going from having my bachelor's in nursing and then going into the psych nurse practitioner program, it was a 2.5 year program. And then I started working about, I would say, 3 years after I started. So, because it takes about 6 months before you get your, after you graduate, to get signed up for the ANCC, to take the test, and then to get your license. Usually takes anywhere from 3 to 6 months for that. And that depends on when you schedule your test. So yeah, after, it depends on your degree in psychology and how many credits will transfer into the master's program. If you do a DNP program, which is a doctorate program, that's going to be another year, year and a half tagged on to that. So it just depends on how far you want to go in the program. And then after you get your degree, you have to sign up for the ANCC certification test. And then, of course, after you get that, apply for your licensure. So that whole process can take anywhere from 3 to 6 months after you graduate. So yeah, I'm glad to hear that you're getting into psychiatric nursing, especially as a psychologist. We had a student that had was a psychologist and decided to do the psych NP route as well. So he was actually dual licensed, and so he could provide really good therapeutic benefit as well as prescribe if he chose to. So yeah, a lot of ways that you can help your clients doing both. So good for you. Soraya Sheki, hi. How to get rid of prolonged and irregular periods caused by anxiety and depression? That's interesting. Usually, PMS, prolonged irregular periods, and things dealing with menstruation, um, isn't caused by anxiety and depression, but the period itself and the way that the hormones are fluctuating, causing the irregular periods, is what causes the anxiety and depression. So this is a little bit backwards. So you may be thinking that the irregular periods are caused by anxiety or depression, when in fact it's really the hormone fluctuations that are happening. So depending on your age, you could be perimenopausal. If you're not in that perimenopausal age, then perhaps you might want to look into something called PCOS, which is polycystic cystic ovarian syndrome, which can also cause painful irregular periods, usually heavy menstrual periods, and because of the increase in testosterone, some irritability, and some problems with mood. So perhaps that could be something that's going on. Some women are just more prone to hormone fluctuations during their menstrual cycle that lead to some of these symptoms, which we would categorize as premenstrual dysphoric disorder. If it becomes very difficult to deal with when you're going through your cycle, usually about a week before the cycle comes, you start getting into either severe depression or anxiety state that makes it difficult for you to function at work or in school. And that would then be considered PMDD. There's a little more to it than that, but it's like PMS symptoms, but more elevated and having more mood type symptoms. And that's typically treated with SSRIs. Like your Prozacs, your fluoxetines, your Zolofts and sertralines. But I would say to talk to an OBGYN about it first before going into using pills, because you know how I am, or maybe you don't, with skills before pills. We have to really be cautious when going directly to a medication, especially a psychotropic medication, which can actually have a lot of harmful side effects and potential issues with withdrawal down the road that could be avoided if you utilize other things in life, like perhaps diet change, exercise, and things like that to better help manage and regulate your metabolism and your hormones that can actually have a benefit on your mood. So good question. Hi, Mike. Mike Bonatillo, can you speak on TMS? Yeah, so TMS is transcranial magnetic stimulation, and it's something that I just recently got certified to do in the office, and am starting to see patients. So if you're in the Vero Beach area and want TMS, you can see us at Lighthouse Health Group. But so TMS is something that is used that you put the it's a coil that you put on the head, and it helps with basically changing the way the electrical patterns of the brain, specifically around the dorsolateral prefrontal cortex, the areas that are typically affected by depression, and the amygdala, hypothalamus. And what it's basically doing is it's sending through this transcranial magnetic stimulation microcurrents to help to create neuroplasticity and brain changes, which is what happens in therapy over time. But with TMS, this you can actually do a treatment for depression and be treated in 6 weeks, so it's actually a lot shorter than therapy. Therapy can be a lot longer than that to see changes. And the thing with TMS is that it's often reserved for treatment resistance. So when you are looking at insurance coverage for it, it would typically get approved for someone who's tried, 1 or 2 medications, usually 2 medications, and have failed. Then insurance typically will pick it up specifically for depression. Now, recently OCD has been approved. And so that some insurances aren't really picking up just yet. Some are. So that would be something that you would have to, discuss with your provider to see if you're a candidate, or find a TMS provider in your area and have a conversation around it. But the thing with TMS is that that I like about it is that it's getting away from using medication, or at least allowing the patient a choice to after the treatment to be able to see if they can come down or come off of the medication because of the changes that are happening in the brain. And the success rate is pretty high. So you'll see about 68% or so go into remission. And I believe it's like 83%, somewhere around there, have improvements, which is much better results than medications. So the results of TMS are, pretty vast and certainly seen in research to be, better than medication, but insurances typically won't cover it unless there's been a trial of medication first. So that's the downside or unfortunate side. But if you have the financial means to do TMS before medication, I would rather do TMS and not do medication just because of all of the issues um, as far as the side effects. So you're on session 23 of TMS and loving it. That's great, Mike. I'm glad to hear that. Yeah. It's some people at first, the noise and like the tapping for the stimulation can be a little annoying, and people complain of headaches and stuff, but you usually will adjust to it after the first week. And then, most people don't, even realize it or notice it. And of course you got your earplugs in and stuff like that. So it's not too bad, but some people, especially if they have anxiety, can be a little put off by that part of it. And the side effects of TMS are very minimal, to the fact of, and limited. Like usually after a session, you may have a headache, you may feel tired, which means it's working. Sleep becomes regulated usually within the first week or two. And headaches and sometimes dizziness can be a factor. If the person has a propensity for seizures or has a history of seizure disorders, it's typically contraindicated, but that's provider specific, like based off the history, whether or not the provider will do TMS on that person. But the risk of seizure is very minimal. So, but I'm glad you're enjoying it. Denise M, hi. So my doctor's putting me on Wegovy soon. I'm taking some psychiatric drugs and wondering if there's interactions. My medications are Zoloft, olanzapine, 10, Lamictal 100, and clonidine 0.2. I'm not sure, right, Lamictal. I'm not sure with Wegovy. This is the GLP-1 agonist type of medication that's out there, like semaglutide type of thing that you inject for people who don't know, for weight loss. And because it's not something that I endorse or use in my practice as a psych nurse practitioner, I'm not really hip on the interactions, but there is a drug interaction checker. If you look in the description of this video, there should be a link to a drug interaction checker that's free from drugs.com. It's a very good interaction checker. So I would go ahead and put that in there, put all your meds in there, and look for interactions to see if there are any. One thing I do have to say about the GLP-1 agonist, though, in my members group, which you guys can sign up for only $4.99, I actually did it was about an hour-long presentation on the GLP-1 agonist, because one of the members was asking about, hey, what are the mental health implications of using these types of medications? Because I believe he was having some anxiety or some depression. And so that got me going into the research and doing all the research. So I came up with that presentation that I did, and it's recorded there. But I found very interesting that there actually are a lot of psychiatric mental health type symptoms or interactions that can occur, symptoms such as anxiety, which in the literature they are attributing to perhaps because it lowers your blood sugar. So hypoglycemia, which can look like a panic attack, you get shaky. So if someone has a propensity for anxiety and they're taking these medications, they can be more prone to more panic attacks or anxiety because of the lowering effects on their blood sugar. And then there's also, they don't know why yet, but there's also a warning for suicidal ideation, which I found very interesting. So depression and suicidal ideation can become, a risk factor and a side effect of these GLP-1 agonists. And at this point, like I said, it's not understood why, but it could be, GLP-1, when you're agonizing that, that's like a hormone. And remember the gut brain connection that I've talked about in other videos, can be a cause there. So we have to look at, take a look at these medications and weigh the risk versus the benefit. So just be aware of that there are potential mental health symptoms like depression and anxiety that can occur with these medications as side effects, but just not sure about interactions specifically with the drugs and how they work and their metabolism. So that you would get on drugrx.com. But thanks for the question. Daniel Duran, hi. Hi, Giselle. Could you please make a video on lithium carbonate? Good idea. Yeah, that's actually one on my list. Tianeptine is a video that's coming out tomorrow. Members got a sneak peek of that one. That was a member requested video. Then we have clomipramine after that coming. And then we have a video on inflammation and depression that goes through that. I have an interview with a neuroscientist who actually suffered from protracted withdrawal, which will be thereafter, and then looking at doing lithium. So I've got that on the list, and Depakote as well is on that list. So yeah, I just don't have the whole list in front of me of all the videos, but I know those ones coming out because those are already in queue. And Raul, my editor, who's bringing me these questions and helping with moderating the comments there, is working on those videos so that we can show them to you. But members always get the sneak peek a week before the videos are out. So that's another benefit of being a member. But yes, lithium carbonate is on the list. If you are a member and you request it, then it actually gets bumped up on that list. So anyhow, thank you for the video idea, Daniel. Muhammad Faizan, hello. Hi, Doc. Quetiapine dose for augmentation with antidepressants. Yeah, so usually the augmentation dose is less than a dose that's used for like a bipolar or schizophrenia presentation. So anywhere from 50 to 150 milligrams is a good augmenting dose. Now, I would titrate it slowly and start at 25 milligrams just because it's very sedating for many people. And of course, you would want to then take it at night. And sometimes even though therapeutically speaking, you're looking at 50 to 150 for depression augmentation. And most people will sit on 150 in the literature if you look at like Stahl's prescribing guide, and that's the XL formulation. But I see results with just using a small, 25 sometimes is all you need, because oftentimes, especially if some of the symptoms attributing to depression are related to issues with sleep. But as you know, I always like to dig in deeper and look for root causes, and I'm not so heavy-handed on prescribing and just giving people drugs and polypharmacy because of many issues, harms that these medications, I'm very aware of that, not just side effects, but things like protracted withdrawal, which I talk about with Tomas, the neuroscientist who was affected by sertraline and was in significant protracted withdrawal for many years. And because I'm aware of that and understand that heavy risk that can occur, I don't just hand out medications like a lot of other providers do. You have to be very cautious. And so when I have someone who's dealing with depression and talking about augmentation, I first look for root causes. I look at extensive lab work. I have my video, Basic Labs for Mental Health, if you want to get an idea of where I start. But that's my starting point. And then based off of the person's symptoms, what they're telling me, I may add more to that or start there. And if I find things, dig a little deeper, and then support that person with whatever they need. If it's nutrient repletion, if it's sending them to an endocrinologist because they have thyroid issues, or sending them to a hormone specialist because their hormones are completely off, then that's what I end up doing based off of the blood test. So yeah, sometimes it's just tweaking their diet, adding in some lifestyle changes, maybe some nutrients, to replete. Sometimes or oftentimes it's gut health problems, very clearly. And then other times it's medical conditions, and sometimes it's a little bit of all of the above. So, that takes a skill to identify that and look at that. But that's one of the things we are supposed to do based off the DSM. One of the things we have to do before diagnosing someone is making sure that medical conditions have been ruled out. And so I really take that, to the extent that I believe it's supposed to be taken, where a lot of providers kind of just say, oh, well, the primary referred them to me, so I guess they've been cleared, and they don't really dig into it any further. And so that's how a person ends up getting polydrugged and on multiple medications, and oftentimes the medications is what makes them feel worse. So yeah, it's definitely a slippery slope. But if I am going to go down that path, that's what I would do with quetiapine. Sorry, I get on my soapbox a lot with these meds, and I know you guys have questions, and a lot of people, especially in the U.S., we're a pill for every ill. We want to take a pill for everything, but really, oftentimes, if you do a lot of the work first, which is my skills before pills approach, a lot of these symptoms can be overcome. Hi, Skelly. You became a YouTube member. Welcome. Yay. Thank you so much. Thank you for the support. Let me get my thing on here. Thank you so much for the support and becoming a YouTube member. There's a lot of videos on there that I have done already. For members. The most recent one was the outline that I did on Tianeptine, and then before that, I did nutrition for mental health, talking about different food sources, and then before that, I believe was the GLP-1. There was one on vagus nerve and breathing exercises for anxiety. Yeah, there's a ton of stuff on there. So I hope you enjoy the videos. And then for the members, I do a members live the first Saturday of each month. So in a couple of weeks, I'll be presenting another topic or answering any questions that you have. So awesome. How bad mirtazapine for weight gain? I'm currently on 10 milligrams of vortioxetine and 12.5 milligrams of tianeptine 3 times a day. I feel like I might need a low dose of 7.5 to 3.25 mirtazapine add-on for sleep and anxiety. So the weight gain for mirtazapine can be significant. Unfortunately, that's one of the downsides of mirtazapine. Now, it's really unclear if this is a dose dependent, meaning the higher the dose, the greater the issue with weight gain. That is unclear in the literature. What I can say from experience is that I see that those who are on the lower doses typically don't have as great a risk of weight gain. So I do believe it is dose dependent, but I just haven't seen that in the literature. So the other thing too is that lower doses tend to be more sedating than the higher doses. So if you're wanting to add that in to help at night for sleep and anxiety, I would say 7.5 or even having that 7.5 dose would be a good place to start. And then with mirtazapine, typically what you're going to see now the thing is not everybody is affected. I believe the percentage is high though. I want to say it's 38%. You'd have my video, I go over the percentages of weight gain in that video. But off the top of my head, I want to say it's 38%, but I can't be 100% sure. But so it's high, but it's not 100%. So not everyone gains weight with mirtazapine. But those who do, typically what you'll see is you'll have a lot of cravings for carbohydrates, and especially at night. That is what I hear from patients who end up with the weight gain. And so it's like this ravenous type of craving and wanting to, and then they can't stop eating once they start, like the ice cream and the pastries and those types of sugary foods and carbohydrates are what they start to crave. So if you start noticing that, I mean, it's really hard. It's easy to say just hold off, don't give in to your cravings. So because it's very intense. But what I tell my patients is, if you only have grapes, only have watermelon, only have fruits like to satisfy that craving, the impact is going to be less than going out and buying a box of Twinkies or cookies or ice cream or whatever. the effects on the weight are going to be less, right? So just think of it in that way. So, and try to avoid the inner aisles at the grocery store, stay in the perimeters so you're not tempted to buy those things. Um, but definitely, it is difficult to manage if you do end up having that, but it's worth a shot. With bortioxetine and mirtazapine, let's see, 10 of bortioxetine, and if you do a low dose of mirtazapine, take the bortioxetine in the morning, mirtazapine at night. Um, because you do have to be careful with serotonin syndrome. Okay, so that is something to be aware of. So watch out for that. And then with the tianeptine involved in there too, the 12.53 times a day is a standard dose. But my understanding is that it can also cause some sedation. So just be aware of that. So you may only need just a little bit of the mirtazapine to get more of a sedative effect, especially if you're taking it at night with the tianeptine. But just be careful not to obviously look for increased sedation or too much somnolence, because tianeptine, usually in the higher doses, we have to be careful with overdosing and causing depression of the respiratory system. That's usually in higher doses, of way above 12.5, but it's still something I need to mention with this type of combination. You just need to be aware of, okay? But definitely separating that bortioxetine and mirtazapine, and just being aware of serotonin syndrome as a risk. Hello, is there any cure for negative symptoms and cognitive dysfunction seen in schizophrenia? Well, oftentimes, the negative symptoms and cognitive dysfunction is a result of medication. But if it's not a result of medication, um, and or if it is, okay, so if it is or isn't a result of medication, but oftentimes it is. Um, the ketogenic diet has shown a lot of especially lately, out in the news, on YouTube, in research. Dr. Chris Palmer is doing a lot of work. If you just research his name, he has a book, Brain Energy. Dr. Georgia Ede has a book, Change Your Diet, Change Your Mind, all about how you can really enhance mental health, especially cognition, depression symptoms, improve mental energy, focus, concentration, all of those things with the ketogenic diet. Um, metabolicmind.com, and I believe it's called charliehealth.org, are websites that can help you with that. Metabolicmind.com, I believe, has information on and I believe even a link to like get into groups, and to help connect you with providers that can help you work on that if you're dealing with some of these severe mental illnesses. And both Dr. George Ede and Dr. Chris Palmer have been doing the ketogenic diet and using that to treat schizophrenia and bipolar, and to help patients get off of medications because they recognize the harms of these medications, and have been very successful. So that's the route I would go, maybe looking at purchasing one of their books as a start, or just looking on YouTube, typing their names, and looking at their videos and kind of understanding how it's done. But it should be done under the direction of a provider, because getting in ketosis, at first can cause a flu-like symptoms. And then once you start having the benefits of the medication, the diet, and you're in ketosis, you may start getting side effects of medication and unnecessary. So meaning that you may not need the medication and need to slowly taper it down as you start improving with the diet. And that takes a skilled provider who understands the use of ketogenic diet, and using it for these severe mental illnesses. It's certainly beyond my scope and knowledge, but I do know it exists, and I do know that those providers specifically have expertise in this area. So I believe that yes, your symptoms could be cured, because there are many stories out there. There's actually a girl, I believe her channel is called Living with Schizophrenia, and she has started this journey. on ketogenic, and she's documenting it. So you may want to look at that channel for some advice and some support as well. But yeah, I wish you well on that journey. Hi, Skelly. I need to be careful with weight since I have been lost and gained and lost weight over the years. Yeah, okay. My largest I was 50 kilograms, now 95 kilograms. Wow. So that's why I asked. Thanks. Yeah, that's a huge change from 150 to 95 kilograms. And kilograms, guys, if you're in the US, that's 2.2 pounds per kilogram. So yeah, that's a huge change. So good for you for being able to lose all that weight. And I hope that you stabilize. And I understand why you wouldn't want to, go back up, and kind of, end up on that same path of gaining weight when you just did all the work to lose it. I can understand that. But yeah, just be mindful of those things with that mirtazapine of increasing your appetite and craving specifically. Michael S. Hello. What's your opinion on treating TD in a 17-year-old with tetrabenazine? This is one of those, I forget which one it is, in Grayza, or it might be the other one. So TD is tardive dyskinesia. And yes, there are medications like tetrabenazine. There are other medications you can use as well to treat it. My opinion on it is that because I'm not in this, I don't work in community mental health anymore. I used to when I first was licensed and got a job. That was the place I interned and did my internship. So that's the place naturally I started working before I understood these types of issues with medications the way that I do now. So long story short, I guess circling back. When I have someone with tardive dyskinesia, number one, I don't work with patients with severe mental illness, and so I'm not really heavy-handed in using antipsychotics, anymore. And when I do see, if I am using antipsychotics and I do see these issues, we back off the dose. That's what I would do first, or find something else, or look for something, that could be at 17 years old. What else could be causing his symptoms that put him on the antipsychotic to begin with? And trying to resolve some of those factors. But I have, like I said, this was a few years ago now, so my memory of it is hazy. I think it was in Grayza was the one, and there was another one that we were using in the office when they first came out for folks, the schizophrenic patients who had TD. And some people did really well with them. And I do recall others having some side effects, and they were intolerable. I remember specifically one patient that stands out when we gave her one of those medications. I think it's the one you take twice a day. I forget there's one that you take once a day and one you take twice a day. So I just forget which one is which at this point, because I'm not working in that capacity. But what I recall with her, she had bipolar disorder, and I believe was on Latuda and had TD. And then we started her on one of those VAT inhibitors, which is what this type of medication is. And she had significant worsening of her symptoms. So it actually did the opposite. And I strictly remember her because she came in and she was just like really like jumping, she was twitching. It was just awful. So we ended up getting her off of that and off of the Latuda and switching her to something else. I can't recall, but I just remember that case specifically because when she came in and she was twitching just really involuntarily and in that way. So we knew it was a result of that medication when her issue was, just a little bit before, the jaw and mouth movements that she was having and a little bit of a tremor. And then when we added that in, it was completely off the chain with her tics. But anyway, so just be careful that these medicines, though they can be effective for many, can worsen symptoms and the TD symptoms in others. but definitely have to weigh the risk versus benefit. Look at that list of side effects. Consider decreasing the antipsychotic first and looking for a different one that may be better for your child. Yeah. Oh, yes. Hello. Hi. I hope you're okay. And I want to ask which benzo has a strong effect on mood? Well, they all can have an effect on mood. I guess I'm wondering if you're thinking about depression, because a lot of them can cause depression or blunting of emotions. Especially because when you're inhibiting GABA so much. The one that sticks to my mind that can do that quite significantly is Valium. It's a very, very common side effect that it can cause depression and even suicidal ideation in some patients. But all of the benzodiazepines have that as a risk, along with, of course, the bind, which is the one of the bigger risks, the benzo-induced neurological dysfunction. Um, the thing I have to say about Valium, though, is that it's typically short-lived when, especially if you're going to cross over from a short-acting because you want to taper off. You want to cross over from a short-acting, like say Xanax or Ativan or Klonopin, to Valium and do like the Ashton method because you want to taper. I always tell my clients, if that's the route we're going to go, that, hey, depression is very common as a symptom or side effect of this. And if you're not, if you're experiencing some now because of you're in this benzo tolerance and withdrawal kind of state and you cross over, it may get worse, but eventually it does get better, usually about a week or two in. But there's some people who just can't tolerate that transition and that crossover and that depression that weighs on them, and so they end up going back to their medications, trying to space it out, maybe up dose and then taper down. So my experience with the benzos is primarily helping people come off of them, and that's just my experience. So yeah, so Valium tends to be more effect on mood, meaning it can cause depression. But oftentimes, if that person can get through that first week of that transition, um, usually tends to die down and not be as severe. But that first week is usually the most significant. Thanks for your question. Hi, Skelly. Tianeptine strangely doesn't sedate me. It makes stress more tolerable. I don't feel like I get quickly overwhelmed and able to avoid going in overdrive and panic mode. It has also made my asthma better. That's good to know. Tianeptine is definitely, the video will be out for everyone tomorrow, but Skelly, you can actually see it now that you're a member, the sneak peek. Yeah, I found it very interesting, and that was one of the members had a question about that medication topic, and I found interesting that because it's not working on the monoamine system, which is like your norepinephrine, your dopamine, your serotonin, like your basic neurotransmitters, which all the other antidepressants are. It's working in the NMDA and opioid receptor area. So it's working in a different area, but because of that opioid agonist effect on those mu opioid receptors, the reason why it's not legal in the United States, not FDA approved in the United States, is because it has a very high risk for dependence, abuse, and then tolerance. Like once people start abusing it, they develop tolerance very quickly to that euphoric effect. So they take more and more, and dosages up to, I want to say 1,000 milligrams, like really, really high dosages. And then of course, then they risk overdose and things like that. And it's becoming a problem in the United States where they've been trying to, guise it as a supplement. And so it's like, I think Tiana Red and Zaza, Neptune's Fix is another name for it, but they coined these gas station heroin. And, unfortunately, in a lot of states, it hasn't been completely banned because they haven't caught on, but many states, I believe there are 13 states that have caught on. Florida is one of them where we banned it completely. So they shouldn't be being sold in gas stations, but in other states they may be. So, and then they're mixing it with other chemicals. And so it's very dangerous. And so the FDA does certainly does not want to approve that medication just because of what's been happening here with the illegal use of it in some states and the guise of using it in a supplement as a nootropic, and people getting high, getting hooked, and unfortunately dying because of overdose, and then some even using it to commit suicide. So I'm glad to hear that it's not causing sedation to you, and I'm guessing probably there's no risk of dependence with you on that small of a dose. But yeah, that's unfortunate because it's opened up a different mechanism of action for antidepressants, similar to like ketamine on NMDA. When you look at that. But I think they just need to figure out how to make it so that it's not creating these euphoric effects for some people, so that there's a less risk of abuse. And I think they're working on that. I mean, one of the good things that came out of the research with Tianeptine is the fact that it kind of opened up this new pathway. So there are researchers out there looking at a new pathway and developing new medications that can help with that NMDA receptor, like medications like Auvelity using bupropion and dextromethorphan, right? That's one way to leverage that NMDA pathway, but also a way to leverage the mu and delta opioid receptors, such as Tianeptine does, but without causing the abuse, factor. So hopefully we'll come up with safer options, but I'm glad to hear that it's not causing that with you. Other options for asthma were Singulair, but the only one has really horrible psychological issues and side effects. Yeah, and it's interesting that it's improving your asthma. I wouldn't know why or how. Maybe it has to do with the beta adrenergic system. There may be some influence there, but I'm glad to hear it is helping your asthma too. That's great. Muhammad, currently on paroxetine, controlled release 1 milligram, venlafaxine 75, lamotrigine 200, quetiapine 5, clozapam, or I guess you mean clonazepam, 2 milligrams. All set, mood is going good, but insomnia is still there. How to treat insomnia with my medication? You're in this polypharmacy area, and insomnia. I would guess this is because you're on pretty high dosages. I mean, 2 milligrams of clonazepam is high. It's like a max dose that you would give somebody. And I'm wondering, you're probably taking it all at once. But if you understand how benzodiazepines work, I would say that that's the culprit. You're having what's called rebound symptoms when it's no longer helping what it's supposed to treat, and now it's making that effect worse. And it's one of the early symptoms of bind, unfortunately, that we see. That and rebound anxiety. Anxiety gets worse. And then your doctor will eventually say, well, you're at the highest dose, Muhammad, so not sure what else we can do. So you can either go down the path of keep adding stuff or consider tapering. I'm guessing you probably don't want to struggle with the tapering, because that is quite a thing. It's a challenging thing. So I don't want to throw that out there as oh, hey, just taper, you'll be fine, because no, tapering has its own set of problems. But you may eventually feel like you need to taper if things just keep getting worse. Quetiapine 5 milligrams is interesting to me because the lowest dose we get here is 25 milligrams. So I'm not sure if that's a typo. So what I would say is maybe leverage the quetiapine and increase that a little more if you're trying to counteract what's happening with the clonazepam. But ultimately, I'm worried that you're heading down a slippery slope here with your medications, and obviously, especially paroxetine and venlafaxine. That's an SSRI and SNRI is pretty dangerous and very high risk for serotonin syndrome. That's really not good practice. So whoever's doing that, but to each their own when it comes to that. But I know I would never have someone on an SSRI or SNRI. It's just not good practice. If you end up with serotonin syndrome, that doctor could be liable for malpractice for sure. Ganesh T, ma'am, I remember last time you said your husband has ADHD and uses binaural beats. How long is it safe to use? Doesn't ear pains, and what else uses? Um, yeah, it doesn't cause ear pain. I'm not sure if you have it in a headset and you have it loud, then maybe. So I would, and he doesn't typically do the headset. He has it on in the background. So binaural beats, and then the other thing he uses is lo-fi focus music. So those are the two different ones, and you can find on YouTube channels that just focus on that, for that just do music for focus. um, so on both the binaural beats and the lo-fi focus channel. So I would say if the binaural beats are causing issues, then try the lo-fi for focus and see if that is a little better for you. And it doesn't have to be so loud. You can lower it, or maybe don't use it with the earphones. Though I know with binaural beats, they say it's best to use it with headphones because of the way it's going in and into the different speakers, the different sides. But he doesn't usually do the headphones. He usually just has it on on the speakers in his room in the office. Why are SSRI handed out so easily? Oh, SSRI antidepressants. Yeah. Quitting with them, I'm horrible. Okay. Hi, Andreas. You bring up a good question. Why are they handed out so easily? It's a demand from our culture. Unfortunately, I guess you could say it started with the advertising of Prozac back in what was that, the 80s, revolutionizing antidepressant treatment because now we have a safer option to cure depression and this whole chemical imbalance theory, which has been negated. The majority of people do not have a chemical imbalance. I would say most of them, if they're dealing with depression, have more of a nutrient deficiency than anything, which can be, cured with diet, lifestyle changes. So, I don't, I guess I could say why they're handed out so easily. Big pharma has a big role in it because they do a lot of they fund a lot of the education for providers. So because they're funding, our education, especially as a psych nurse practitioner, we learn a lot of psychopharmacology, and it's very heavy-handed in psychopharm, which is medication. So it's medication based. Like that's our arsenal. That's what we're taught to use, and very little on therapy. So, and I hear this from psychiatrists as well. A lot of their, in med school was very heavy-handed with medications, and this chemical imbalance theory is still being thrown around, even though it has been negated in research. Not to say that no one has a chemical imbalance, but it's very rare when you're looking at the population and how many people are given these medications. It doesn't compute. So you don't have a Prozac deficiency, you don't have a Zoloft deficiency, you most likely don't have a serotonin deficiency. So why are they being given? Well, 30 to 60% of people will respond. They say about 30% of people respond to the first antidepressant, which is very low standard. This would not go well if, say, you have a very bad pneumonia and you give someone a drug, maybe 30%, it might help. No, we're a little more advanced in that we can identify the pathogen and give you an antibiotic that will target that pathogen when it comes to infections and things of that nature. But when it comes to mental health, we just kind of throw roll the dice or throw the darts at a dartboard and say, okay, today I'm going to give you Lexapro, or I'm going to give you Prozac, and we're going to cross our fingers and hope that it helps. And for the majority of people, it doesn't. So then they try another medication. Maybe that one helps, maybe not. And then you have, when they say up to 60%, so by the second antidepressant or third, you get about 60% of people will respond. But then after that, you get treatment, you end up with treatment resistance. And so then we have the adjuncts, and and of course, who is profiting here? Big pharma. The pharmaceutical companies are profiting big time. So it takes providers like myself, and there are many out there, to say, hey, I'm seeing a pattern here that doesn't add up. Questioning the norms, questioning, what is going on with the patient in front of you, and thinking outside the box. That's what got me into, wait, the conventional model, and kind of looking outside the box, because I saw a patient who was going through significant benzodiazepine withdrawal, and everyone wanted to categorize her as basically crazy and med seeking and borderline, put all these labels on her when she was really going through significant issues coming off of Klonopin. That's what got me thinking, oh, wow, like this is pretty serious. Started looking into finding Ashton Manual, finding, then, helping patients go through that, and then finding out antidepressants can be just as worse as the benzodiazepines. So it is unfortunate. We are working right now to get the information out there for providers, and to be cautious. I think ASAM is working on guidelines for providers on slowly tapering patients off of benzodiazepines. That's a start. I know it's not the SSRIs, but that's a start. And we have Dr. Horowitz, who came up with the Maudsley deprescribing guide, that helps with the antidepressants and the benzodiazepines and the GABAergic drugs. He was, and he still is, a very loud voice in this community of, hey, psychotropic medications cause harm, and oftentimes more harm than good. So it is unfortunate that they are handed out so easily, but I think with time, and unfortunately, the other thing with research and clinical practices, there's this lag with, hey, we find this in the research, but it takes like 10 to 20 years before you start seeing the change in clinical practice. That's unfortunate. We're hoping that with the use of YouTube and Instagram and TikTok and other providers out there, like the Taper Clinic with Dr. Yosef Withduri and the work that he's doing. There's also Free Range Psychiatry, Dr. Kendra. She's big on Instagram, but she has a big movement of getting away from psychiatric medications and more of a holistic approach. So there is a movement there. There are providers out there. Our voice, is small, but it's growing. And I think that the more and more that we talk about this, we bring it to the awareness of the people, the more that prescribers will hesitate to hand out SSRIs so easily, and that providers will start with recommending therapy first, like really they should be doing, and then looking at other factors like lifestyle, nutrition, diet, social aspects. You have to look at the whole body, because we have a neck. We can't just look at the brain singularly and say, fix me, fix this part. We can't do that. We have to look at the entire picture. So I'm glad that you're getting off of them, because it sounds like you might have been injured from an antidepressant, which I feel for you, because I know the pain that people go through. But I do know that there's hope, and that you will get better eventually. Each patient's road is different. So I know you feel it's very horrible right now, but it does get better with time. And once you're off the medication, and hopefully you don't get into a protracted withdrawal state, you realize how different you were on the medicine versus off the medicine, and then you can start working on building your skills and using your diet and lifestyle as a way to move forward through your journey. So I wish you all the best, Andreas. Skelly, the strangest things happened ever since I started with Tianeptine. My blood level of 40-oxetine dropped from 53 to 19 after Tianeptine, like it decreased its effect. That's very interesting. I'm not sure how or why. If the NMDA and working in the glutamate modulation, because vortioxetine does have some effect, but I'm wondering, this may be a drug, the way it's metabolized. I'm not sure if the drug interaction checker would have information on Tianeptine, because it's not something, it's not a medication in the US, but you might want to try that and see in the drug interaction checker if Tianeptine and vortioxetine have, maybe Tianeptine is inducing the metabolism of vortioxetine. That might be what's going on. That's what I would look into, because it's lowering the level of it in your blood. So that sounds to me like maybe this combination, Tianeptine, is inducing the metabolism, so making vortioxetine metabolize more quickly in your system. So definitely look into that and talk to your provider about that. I saw they're developing Tianeptine oxalate naloxone combo. It's in phase 2. Oh, so that's a way to help negate the opiate abuse potential. That's great. Hopefully, that could work for sure. Yeah, that's how with Suboxone, that's how they got around that, with adding in that naloxone. So yeah, that sounds like a great idea. Thank you for letting me know about that. Cats Exotics UK. Hello. Why does drinking alcohol make you very sleepy on aripiprazole injection 400 milligrams? Well, if you're on aripiprazole injection, so you're getting a steady dose of aripiprazole. This is a long-acting injection, so that's going to be, aripiprazole is Abilify. It's going to be in your system, steadily long-term, usually a month. So when you're drinking alcohol, remember, alcohol is a depressant, and you're going to be more sensitive to those effects. And that's why alcohol should never be combined with psychotropic medication. So even though you're not taking a pill and then drinking alcohol, you still have that medicine in your system. And so you really shouldn't be drinking alcohol at all. And a lot of it has to do with just enhancing the sedative effects of the medication, the aripiprazole, and making that side effect of that medication more pronounced. So yeah, and that can be dangerous when you're mixing alcohol with antipsychotics or even antidepressants, because it can also negate the effects. If you're taking it for bipolar depression or schizophrenia, and you're drinking alcohol, obviously you're now going to increase your brain inflammation, increase your risk for hallucinations, increase your risk for depression. So just not a good combination at all. So just take this as a note that your body's telling you, stop drinking alcohol. That's what I would say. Michael S., does TMS treat schizophrenia? No. Well, I should say at least no, not researched yet, not something, it's right now approved for depression and OCD. And we do use it with depression and like mixed anxiety. The anxiety piece, if you're doing depression and anxiety and you don't have an OCD diagnosis, that anxiety won't be covered. So it's like an out-of-pocket cost. But treating schizophrenia, I haven't seen any research. There may be some, maybe they are looking into it, but as far as I know right now, no, there are no indications for the use of TMS with schizophrenia. If there's a comorbidity with a major depressive disorder, like a schizoaffective type presentation, there may be benefit to treat those depressive symptoms, but you're not treating the schizophrenia, the psychosis part of that. Ganesh, is TMS and TDCS effective for attention deficit? Do you recommend for attention deficit? Um, I'm not sure the TDCS, that acronym is not familiar to me, but TMS does not have an indication for ADHD. Um, though when patients are receiving TMS for depression, they do say they feel like their concentration is better and their mood, obviously with their mood getting better. Because remember, when you're in a significant depression, especially if it's affecting the hypothalamus area of the brain and the prefrontal cortex or cognition and those types of things, one of the symptoms of depression is poor concentration. So when you start working on those areas of the brain with that, causing that neuroplastic change to occur, then it enhances that. But if you just have a ADHD diagnosis, is it going to affect it? There's no FDA approval for that. And I haven't seen any research on that. So I would say no at this time, but I wouldn't say it's maybe in the future we might see some benefit for ADHD just specifically, but at this point in time, no. Danielle Duran, I don't know if this is common or not, but I was getting blurry vision on Depakote and couldn't read my book. Blurry vision on Depakote, that is a side effect. Blurry vision can be a side effect of Depakote. If that is happening with you, you want to consider lowering the dose and talking to your provider about that. Maybe you need to split the dose to even out the dose a little more. Maybe it's a little too high for you. So discuss that with your provider. I do know blur vision is a side effect of Depakote and can be a side effect. So definitely look into that. Strike 9, what is the best treatment for flood hurricane survivors? Good question. Therapy. And I'm glad you bring this up because my office managers sent me a message and she's like, hey, how about we offer a discount for Hurricane Milton survivors. We just went through Hurricane Milton here, and we weren't affected as much by the hurricane as we were with tornadoes. A lot of tornadoes came before that hurricane and affected a lot of areas in the Vero Beach surrounding areas. And so anyway, certain communities were affected. And I said to her, because my role there is medication driven provider, where we're looking at these things and like root causes of a depression, anxiety, and putting someone on, either nutrient regimen, supplements, and then putting them on medication, etc. And I said to her, well, this is a situational thing. So this isn't like I'm going to be investigating like, why are you depressed or anxious when I know the root cause is the situational anxiety of you just lost your home, right? So treatment for this is therapy. And that's what I told her. I said, how about we do, some type of promotion and benefit for those with Hurricane Milton by offering therapy or offering alpha stim with meditation. Alpha stim is the cranial nerve stimulation. You clip to your ears. It's a medical device, and it offers very similar benefits as TMS actually, but takes a lot longer to get those results. But the one thing about alpha stim with anxiety is that the anxiolytic effect of doing just a 20-minute session is often noted. I want to say it's about 70% of people who do that in the first session will say, wow, I feel a lot calm, because it's working indirectly on vagus nerve, but it's also working on other cranial nerves. But with these oscillations of electrical currents, basically creating some neuroplasticity and neuro changes that help with anxiety, insomnia, and depression, which a lot of patients or people who survivors of floods, hurricanes, tornadoes, etc., are going through a lot of hyperarousal anxiety. They're probably having a hard time sleeping. They're probably having depression, but this is situational. This isn't something we throw medications at or try to say, what's causing your anxiety or depression? Let's get to the root cause of it. When I know the root causes, obviously, you just went through a very, very tragic, traumatic experience. And so therapy, doing vagus nerve work, so working on the parasympathetic nervous system, doing somatic work to help. So basically anything that is going to help calm your nervous system down, work on getting that hyperarousal to a state where you feel safe, because that's one of the main things that these survivors need, is a feeling and a sense of safety, grounding, and in therapy, working on the negative thoughts, the self-talk, the rumination that goes on because of an experience like this, or if you're experiencing trauma, doing the trauma therapy work. EMDR has been shown to be very helpful for hurricane victims. I believe with Hurricane Andrew, the very first like papers on EMDR, I know one of the therapists who did a lot of the early research, and she was doing that research through Hurricane Andrew and using EMDR, helping those victims, and it was very effective. So so things like that can be very effective as well. So a lot of the treatments, when we're talking about a situational stressor like that, is going to be therapy and work that you can do, body mind work that you can do. Some people do well with yoga. Some people do well with different stretching exercises, um, somatic exercises to help with the nervous system, like I said, vagus nerve exercises, etc. So it's just dependent, on the person. But certainly, if you're experiencing a lot of anxiety from a situation like that, it's understandable. But you definitely don't want to be going down the route of using pills. You want to see a therapist and start using skills and get your feeling of safety back. But good question. Thank you, Strike 9. Aston Holtz, hello, I'm on Concerta, 36 milligrams and atomoxetine, 50 milligrams. Okay. They want to add 1 milligram of Rexulti for anxiety. Oh boy, because it will not blunt the Concerta, but I want 15 milligrams of Cymbalta, but there's concern it will cause updose Concerta. Yeah. If you're going to add in Cymbalta, well, my main concern is going to be serotonin syndrome, and increasing anxiety. Adding Rexulti for anxiety, that's interesting, because you're going to be blocking some dopamine with that. It has D2 partial agonism. So, so I'd be concerned there. And you're already taking atomoxetine and Concerta and still having issues. I would be looking at what else is going on, Aston, to be honest with you. I would say that there is concern with the 50 milligrams of Cymbalta. I would be more concerned with serotonin syndrome with everything. And the CYP2D6. I'm not sure if there is something with that Concerta or not. But I would be looking at zinc as a possibility. Zinc, I would check your zinc RBC, your serum zinc, your copper RBC, serum copper, ceruloplasmin, and zinc copper ratio. Oftentimes with ADHD, we find this, that copper is low or suboptimal. And yeah, zinc is low or suboptimal, and copper is on the higher end or too high. The other factor with someone with significant ADHD, especially if you're having anxiety or irritability with that, I think HPHPA, which is something you would get from an oats test, like a Mosaic, Great Plains, their oats test includes the marker for HPHPA, which is a Clostridia bacterial marker. And that marker, even if you just do the MOATS, the microbial organic acid test from Great Plains, not all of the MOATS or oats have the HPHPA marker. So that's why I'm saying the Great Plains, because I know that they do. So definitely, that is another one that jumps to my mind. Instead of going right into like keep adding medications, because you're going again down a slippery slope for sure. Drug interactions, side effects, etc. That could be contributing to your issue. And anxiety could also be caused by too much stimulation. So you're getting with the Concerta, which is basically a long-acting or very long-acting extended release methylphenidate, and then atomoxetine, which is Strattera, which is a norepinephrine reuptake inhibitor. So you're getting norepinephrine and dopamine reuptake inhibition and stimulation from Concerta, and you're getting norepinephrine reuptake inhibition from atomoxetine. So no wonder you're anxious, because you're increasing your catecholamines, which is your sympathetic nervous system, your fight or flight, too much. So I would say, yeah, no wonder you're anxious. I would say, hey, let's start decreasing some of these medications. I would start with decreasing atomoxetine, get that back down, and look at those some root causes of what's causing this presentation of ADHD and anxiety, instead of adding more medication, because again, you're going down a slippery slope. So I wouldn't add medications at all. I would investigate what's going on. Do also an omega-3 check. Do those basic labs that I talk about in the basic labs videos. That's like a no-brainer. But I would look more closely at the zinc copper ratio, and then look at the moats, the HPHPA, cryptopyrroles, which is pyroluria, could be something else that could be a factor here. Usually with that, the anxiety is very significant, and just very, very irritable, very anxious with a pyroluria presentation, irritability. And oftentimes that can look a lot like to the HPHPA positive patients that we see. So, yeah, those are the things I would be looking into besides adding more medications. And I would actually be more, have a greater propensity to lower your medications if you're having anxiety. I'd say this, then you're being too stimulated. That's what I would be thinking. Skelly, good point, I think. Thanks. I'll bring it up with my provider. I'm slightly slow metabolizer of CYP2D6, so technically vortioxetine should be higher. So Tianeptine is probably speeding it up, or other mechanisms. Yeah, definitely something to consider for sure. So definitely having that conversation would be great. Okay. Hello, Ephraim B. What could be a feasible solution if a family member is showing prosecutory delusions, but denies to visit a professional? Yeah, because probably they're paranoid. But recently showing more risky behaviors. I suggested 988, but didn't work. At this point in time, if they're having prosecutory delusions, oftentimes they start, blaming other people or themselves, or they start having, ideas about conspiracy theories, religion. I mean, there's a whole list of ways that this can go. So oftentimes they're paranoid as well. So it really depends on how severe this is. But oftentimes when there is a patient in this type of state, you need to get them into emergency treatment, and have the family member. In Florida, we call that a Baker Act, involuntary treatment, and get them to a point where they're no longer having the delusions. And then when you get them out, I would start looking at some what's going on underneath the hood, so to speak. I would want to do an oats test, look for that HPHPA, because psychosis can be something that can happen. But also look at other, look at their dopamine. Are they a COMT MET? That can be problematic and cause too much dopamine. So I would be looking at root causes then, but at this point in time, they're not going to agree to go anywhere to do anything. So unfortunately, because it's to this point, they most likely need involuntary commitment, which they'll probably end up getting medicated to at least get these delusions and hallucinations, whatever they are, under control. Then you can start reasoning with them and saying, hey, we may not need to be on these medications forever. I know they told you that in the hospital, but we're going to work on this in a holistic way, and let's find out what's going on. Start talking about dietary changes, get them off processed foods, get them on an anti-inflammatory diet at the least. If they are all in, get them on keto because they're going to feel a whole lot better, and avoid the polypharmacy route, that the conventional docs will certainly end up having them on. But unfortunately, when they're at this point, to get them help, 988 isn't going to work. They're going to be paranoid about it. And they're going to need, a commitment, basically in the hospital, just to get them to a point where they can think clearly, and then sell them on looking at some root causes of what could be potentially going on with them. That's what I would be talking about. Rohit the core is aripiprazole increases the obsessive compulsive symptoms. It can. That's actually a warning. What they found is very interesting with the Abilify. Rexulti can too, but to a lesser degree, because the Rexulti and Abilify, they're like cousins. You got aripiprazole, brexpiprazole, but there is this warning that it can cause obsessive compulsive type symptoms, in particular with gambling, which is odd, I know. But that, and then also they also found like risky behaviors, like for instance, like getting involved in relationships, extra, having affairs, like multiple relationships, that kind of a thing, and which kind of looks like a bipolar presentation. So that definitely is something that you need to be aware of. And if it is increasing any type of obsessive compulsive like symptoms, you're doing more risky behaviors than you normally do, make sure your provider is aware that this could be an effect of aripiprazole, and not just says, oh, well, your symptoms might just be worsening because of your disease, so they increase the dose. You want to make sure that they're aware of this, because this is a fairly new labeled side effect or warning. I think it's on the warning label now of the of aripiprazole and brexpiprazole, and I'm not sure if other antipsychotics have that warning as well, but I do know for sure aripiprazole and brexpiprazole do, and I would say maybe that's been in the new in the past couple of years or so. So definitely something, if this is happening to you or a loved one, that you bring it up to your provider. If you go on to dailymed.com, they have it's the NIH. They'll have all the most current labels of the drugs, and you just type in aripiprazole, it'll pop up, so you can have that, and maybe just pull up the label for them and show it to them and say, hey, this is what we're dealing with, and we see it's part of this warning for this medication, and they may want to lower the dose or get you on a different medication. Okay, Amir, hello, hi. I'm using Wellbutrin XL 300 milligrams and I'm experiencing brain fog. I started this medicine 1.5 months ago. Is it normal and temporary? Should I talk to my doctor as soon as possible? After 1.5 months of bupropion, brain fog, no, typically you're going to experience an increase in concentration, an increase in motivation. When I hear brain fog, I start thinking of omega-3 deficiency, very common side effect of that. So we want to optimize omega-3s, and you can get an omega-3 check. And when I say optimize, I want to see that percentage of EPA, DHA, the omega check ratio, I believe it's called. We want to see that percent above, 6%. Optimally 8% is what I'm aiming for. So if you're lower than that, then certainly you're going to do really well with omega-3 supplementation. And usually you need really high doses, like 2 to 3 grams a day. Some people will need up to 12 grams a day, but 2 to 3 grams is a place to start. Um, but definitely do an omega check first. Um, what else with brain fog? You could also try green tea. It has antioxidants. So if you have inflammation going on, because that's the other thing that I think about is brain inflammation, you can look at interleukin 6, tumor necrosis factor alpha, if you're concerned about that, HSCRP, which is high sensitivity C-reactive protein, and a CRP, a SED rate. Those are inflammatory markers, because that can also be attributing good antioxidants, superfoods like organic green tea that you steep and you drink, can help because it has EGCG, and L-theanine also will help with focus and concentration. It's something that I do all the time. I have mine here. I'll have the sip now. Mm. It helps keep me focused for these lives. But yeah, I would be looking at other things, because at 300 milligrams of Wellbutrin and having brain fog, that should not be happening. So I would be thinking, hey, if bupropion's trying to increase norepinephrine and dopamine, and my effect is brain fog, what's going on in my brain? There's something not connecting or communicating there. So that's why. And oftentimes when you start medication is when a lot of these things become more noticeable. Like you start an SSRI because you think you have a serotonin deficiency, you're depressed, and either you end up becoming more blunted, more depressed, more there's something wrong with that system. And oftentimes when you dig in, you find there's a nutrient deficiency, there's something we're missing, B vitamins. So certainly do those basic labs for mental health, but focus on omega-3, do omega check, do inflammation markers, things like that, to look a little deeper of what else could be causing the brain fog, because you'd be surprised. B vitamins like B12 and folate are also common issues we see, because you need these vitamins and nutrients as cofactors for the production of your body to naturally produce neurotransmitters. So if you're trying to stimulate it artificially and now you're getting brain fog, it's because you cannot produce what you're supposed to produce to get the benefit. And that is not a Wellbutrin problem. That is a biological, nutritional issue. So you need to figure out what's going on there, Amir, and talk to your doctors about that. Andres the Great, hell, I'm on 225 milligrams of venlafaxine. It feels high. Is it? No, I know that seems high. 350, 375 milligrams is, typically the upper limit. So no, this isn't a high dose, though it does seem high. You usually start at 75 milligrams. Some will start a little more conservative, 37.5, because venlafaxine comes in, I think the smallest is 37.5, and then go up. And then therapeutic dosing is anywhere from like 150 to 300. Some providers will go up to 375, that range. So it is on the higher end, but definitely talk to your provider about it if you feel it's too high. And if you're going to come off of venlafaxine, you have to do it very, very slowly, very, very cautiously, because it is one of the most difficult antidepressants to taper. Luckily, it comes in liquid, and I always have this on my desk lately but this, the Maudsley Deprescribing Guide, great guide to help you through it. And what you'll end up doing, what you'll see in that guide, getting off, and I have the link to that book down in the description, is that it'll recommend that you switch to liquid twice a day dosing, and then slowly, and depending on if you've ever tapered off of a medication before or not, how long you've been on it, etc., would depend on how fast or slow you go. If you're not sure, starting with the slowest is always safest, And then if you're tolerating it well, you can kind of start speeding it up to a more moderate and then faster taper. But even the fast taper, will still take you a while to come off. It's still relatively slow compared to conventional medication practices, which will say, oh, just half it, no big deal. And then half it again, that kind of a thing, or just reduce by the lowest 37.5 milligrams. You're going to be feeling pretty hurt, especially if you've been on it for a while, if you try that route. And it won't happen at first. You can usually take bigger chunks in the beginning off. It happens in the very small dosages. That's where receptor occupancy is the greatest and where the effect is seen the greatest. So when you try to remove that, it's like jumping off of a cliff. So you really have to be super cautious on the lower dosages. And that's all explained in the Maudsley Deprescribing Guides. I recommend anyone, Amir, the one who's becoming a psych nurse practitioner, any practitioner to get this because it is a necessity. If you do not want to cause harm to your patients when they need to taper off of medications, I would highly recommend you getting that book and using it as a guide. And anyone can use it. I mean, it's not just for providers, but definitely if you're a provider, it is a must-have book that you should have in your library because it will certainly help with reducing the risk of protracted withdrawal and withdrawal injury that can occur with these medications. Thank you for bringing that to our attention, Andreas. Abdul Rahim Fox, I'm on venlafaxine 300 milligrams, olanzapine 20 milligrams. I have really bad insomnia. On Tuesday, I'm seeing a doctor as they want to add trazodone or amitriptyline for sleep, which is better for sleep. Well, both are going to be good for sleep. Okay, so if we want to say which is better for sleep, it really depends. I would say amitriptyline is probably going to give you a little more sedation, but higher risk of side effects. It's a tricyclic antidepressant. You'll need just a very little bit, maybe just 25 milligrams to get a sedative effect. But I'm surprised with 20 milligrams of olanzapine, you're still having insomnia because olanzapine is very sedating. That being said, I would say trazodone would probably be the safest. With any of these combinations, you still risk serotonin syndrome. I would also wonder with the venlafaxine at 300, maybe if you lower that, would that help the insomnia? Because a lot of times insomnia is a side effect of SNRIs. So just a thought. And I don't want to get into my whole soapbox like I've been saying each time with make sure you're looking at root causes, make sure your magnesium is good, your vitamin D is good, your zinc is good, all nutrients necessary for serotonin conversion to melatonin. B6, B6 you can't really measure though accurately. None of the serum tests, that's a waste. But B9, B12 for sure. Homocysteine would be a good marker to kind of look at that. Like a B6, B9, B12 picture. If you have high homocysteine, you can be suspicious of B6. If you have cryptopyrroles, certainly you're low in B6 and zinc. But those are things that I start thinking about, especially at 20 milligrams of olanzapine. Most people would be knocked out on that dose. But if you've been on it for a long time, neuroadaptation is sneaky, sneaks up on you. And now, you adapt to it. So if you've been on it for years, maybe you're doing well, and then now you're having issues, that could be from neuroadaptation. So if we're just strictly talking about trazodone and amitriptyline here, I lean more towards trazodone. It's a little safer. And I would start 50 milligrams, say take it in half first, just to make sure, that kind of a thing. If you don't really get results from that, and you can go up as high as, 200, 400 milligrams with trazodone, but you would really have to be careful with serotonin syndrome in this clinical picture here. And then amitriptyline, you would start low, like 25, 50 milligrams. Some patients, just 10 milligrams of amitriptyline will do it. so you may just want to start being more conservative and start there. But even with amitriptyline, really have to worry about serotonin syndrome, and just look at the side effect profile, and then also go to your drug interactions checker. Off the top of my head, nothing is sticking out with metabolism. As far as the way these medications are metabolized, maybe some drug interactions. So I would also look that up. That would also be something to do on the drug interaction checker, and see if there could be issues with choosing one versus the other as far as how they're metabolized, and that as a factor. But looking at both of them, I would lean more towards starting at trazodone before amitriptyline, just because of very heavy side effect burden with a tricyclic like amitriptyline. Good question. Wes, do you help with your patients to get rid of benzos? Yes, I do. A lot of my patients are coming off of medication, so I help them with deprescribing. And benzos are one of the most difficult. So I get more patients who are coming off of benzodiazepines versus the antidepressants, just because of how difficult it is to get off benzos and all of the different nuances that can occur with trying to switch to diazepam. If you can't tolerate that, then what do you do? And I mean, there's a lot of different factors. And of course, the issues with bind, benzo-induced neurological dysfunction. I have a playlist that talks about. I think I have it under taper or something like that, but or taper help or something, but or deprescribing. Anyway, can't remember what I labeled that playlist, but I have a lot of videos on there about benzodiazepine, coming off of them, some steps, what to consider, and those types of things to help get you on your way. And like I said, if you can get this book, the Maudsley Deprescribing Guide, it really walks you through, some really good tapers. The thing I would say is that if you ever get stuck, a lot of people, I'll explain some mistakes, I guess is a good way to put this. A lot of mistakes that people make when they start tapering. Number one, you get eager and you want to taper and you want to get off the medication, and you start going fast. If you go too fast before your body has a chance to stabilize, that catches up to people very quickly, and can all of a sudden be like, boom, bind symptoms, which is the benzo-induced neurological dysfunction. But when you look back, and especially those people who are monitoring their symptoms, there are clues that you need to slow down. For instance, if you're going every week on a taper, and the day before you taper, or a couple days before, you start noticing like, my body's starting to feel like it's going to start to withdraw, like it knows the taper is coming, you need to slow down. So, and I never like to do a week. I like to do 4 weeks is always, like, especially if someone's been on it very long, is already having withdrawals. I like to do 4 to 6 weeks, sometimes longer. And some people need to hold for months at a dose. That it happens in very difficult cases, but some people seriously need to hold for months. So number one mistake, people are eager. They want to taper too fast, and that can lead you into protracted withdrawal or this benzo-induced injury. Second is that they start adding rescue medications. For instance, you're trying to taper off of Klonopin, and you're in benzo withdrawal tolerance, and you try to come down, but you feel like, oh, I can't make it. But because I'm not responding to this, I want to add, say, a Xanax or an Ativan to help get me through. Wrong. Because you're never going to, it's still a benzodiazepine. And now you've just added another layer of that in there. And yeah, you may get relief, but you're not resolving the issue. When you're in benzo tolerance, the only thing that is going to get you out of that is coming off of that medication. But on the other hand, right, that's a very difficult road. And so there are risks versus benefits you have to weigh. So are you serious about tapering and wanting to come off this medication? Are you really seriously into coming off? Or do you want to just stay on the benzo and substitute. You know what I mean? Like, so that becomes a convoluted picture. Um, the other mistake, very common people make, is they start taking all kinds of supplements. I'll have someone come, they're on 20 supplements, 30 supplements, because they're trying to, the quick fix. They're trying to look for the, well, I heard NAD, I heard NAC, I heard magnesium, I heard this, I heard that. There are some supplements that can be helpful, but by and large, from my experience with this, there isn't a miracle supplement. And there isn't a combination of supplements that are going to get you through this. It's time, it's patience, it's honoring your body's need to do it very slowly, to hold, to get through it. And you need good therapy to get through it. You need to have good skills. So before embarking on a benzo taper, you need to make sure you have skills in place. You need to know that I can downregulate I can get my nervous system stable. I can get, for instance, if I'm hyper aroused, if I'm starting to have these symptoms of neurological problems, I can get my nervous system to a place where it feels safe. So the withdrawal and the anxiety that's produced because of that is lessened. So you really want to focus on that. And that's, I guess that's another mistake people make, is they get so eager that they just go for it without really looking at what was the reason why I was anxious to begin with. I just want to start tapering. But why were you anxious? Because that problem is most likely still going to exist. Did you do trauma work? Did you work with a therapist? Do you have skills in place to tap into when you go through withdrawal? Because even if you follow this book by the T, even if you do an even slower taper, which some people do, and you're following that by the T, and you're holding, you're doing, it's not an easy road. It doesn't mean you're going to be withdrawal free. It doesn't mean you get a ticket and bam, you're on easy street. No, it's still, you're still going to have symptoms. It's still going to get difficult, especially when you get down to the bottom. So I guess another mistake would be having the perception that because I'm tapering slowly, I'm not going to have withdrawal symptoms. That is not the right perception, because you will have withdrawal symptoms. You can decrease the severity and decrease the risk of injury and protracted withdrawal by going slow, but you will have withdrawal symptoms, and you have to learn how to honor your body's need for time in between the steps, whether that's holding, for weeks, or holding for a month or two before moving on to the next, stage and lowering that dose. So lots of things to consider. So yes, I do help patients get rid of benzos, but there isn't an easy way to do it. And there's a lot of things to consider. So if you're someone who really wants to get off of a benzodiazepine, you need to be mentally prepared for what's to come, and do all the work first before just saying, okay, I'm just going to follow this and boom and do it and think that you're going to get off scot-free. Some people do. Some people are lucky. They can be on it forever and they say, hey, I just stopped it and I was fine. Believe me, consider yourself lucky, but most people are not. And I discussed that in the video on I think I called it, I think it's the bind video. I talk about that. So maybe looking into that, but yes, I do help people get off of them. Charlotte Dilene Jesperson, hello. My depression from PTSD is not getting all good on duloxetine 90 milligrams. What can I do? Make sure you're seeing a therapist as well. Again, you can look for root causes of your depression. Looking at the basic labs for mental health would be a really good start there, to see what could be causing the depression. But I would make sure you're in therapy and working with a therapist who understands trauma. EMDR may be good for you. But when you're on duloxetine 90 milligrams, you're certainly on the higher end of a therapeutic dose. So I would say before thinking of adding on, you could try increasing it to 120, maybe splitting it 60 milligrams twice a day. Talk to your provider about that perhaps being an option. But before even doing that, I would be more curious as to if you're doing the work in therapy, you're doing the work on your nervous system, because vagus nerve has a lot to do here. And the gut tends to get, with trauma, very dysregulated and inflamed because of that, because of the autonomic instability and dysregulation of that parasympathetic and vagus nerve. If you've looked into all that and you're still struggling, you did all the work, then I would look into perhaps something like TMS might even be a better direction. But oftentimes, when you start digging and you start looking at potential root causes, you're going to find something, after going through the therapy, the nervous system regulation, look at biological factors, because not everybody who experiences trauma ends up with PTSD. And the reason for that is vast. A lot of people are still, a lot of theories out there, but resilience has a lot to do with it. And we become resilient for many reasons. One of them is a good lifestyle, nutrition, exercise, those types of things can certainly help prevent the onset of PTSD after experiencing a trauma. But if you are already experiencing a trauma, if you experience a trauma and are have a clinical diagnosis of PTSD, then certainly doing the work in therapy is going to be key. Not so much medication. And then looking at the biological mechanisms that maybe opened you up to being susceptible to the trauma. So making sure omega-3s are optimal, vitamin D, B vitamins, 12 folate, B12, B9, homocysteine isn't high, those types of things I would be looking at when it comes to depression. So yeah, look at that video, Basic Labs for Mental Health. Perhaps you'll find some answers there, and talk to your provider about that and see if they can help you get to that root cause. And hopefully you're in therapy. Therapy would be number one in my book. Okay. Hi, I'm diagnosed with GAD and ADHD, currently on Zoloft, and helps a lot with anxiety. However, I've never been treated for ADHD and looking to start treatment. Zoloft plus a stimulant safe. You do have to be careful with the anxiety. So if Zoloft is helping your anxiety, that's good. And when you're looking at a presentation of anxiety and ADHD, always want to treat the anxiety first, because oftentimes anxiety symptoms look a lot like ADHD. And if you start with the stimulant first, you can actually really increase the anxiety because stimulants are stimulating. So is it safe? Well, technically speaking, you can safely be on Zoloft and a stimulant medication. You do have to, though, be very careful with serotonin syndrome. So making sure your dose of Zoloft isn't too high when you add in a stimulant. And also be careful for exacerbating your anxiety by increasing your catecholamines, by increasing norepinephrine, epinephrine, dopamine. You need to be cautious with that because that can lead to increasing anxiety. And like I've been saying to everyone here, just make sure that you're digging in and looking at root causes of potential root causes of your ADHD symptoms or even anxiety symptoms. Do your labs for mental health and just make sure that those are not factors as well. But overall, stimulant and Zoloft is safe. You just have to watch out for serotonin syndrome, increasing risk of seizures, increasing your risk of increasing anxiety, irritability, and those types of symptoms. And if you have any cardiovascular history, increasing the risk of those issues like irregular heartbeat, palpitations, etc. So those are all things to consider and have a discussion with your provider about it. MDP lady, speaking of abuse, the stigma with ADHD meds being addictive is frustrating. Yes, it is. So if someone has type 1 diabetes, is their insulin addictive too? No, no, it's not addictive. It is something type 1 diabetes that they need because they lack the hormone and the ability to produce it. So without it, they die. Without ADHD meds, someone with ADHD doesn't die. But when we're talking about stigma with ADHD meds and ADHD meds being addictive, yes, it is frustrating. But the fact is that they're very addicting. And unfortunately, people who have a propensity for addiction and abuse obviously make the picture more convoluted. And because we have a crisis with addiction, primarily it's opiate driven with the fentanyl crisis and opioid epidemic. But that heightens the awareness of providers because there's a scrutiny that is put on the providers now through the mechanisms that we have to prescribe. So the DEA here in the United States, I'm talking about. So I'm guessing that you're a U.S. resident. And this is what you're talking about because this is an issue here. And so the stigma comes from many factors. From a provider's perspective, I have the DEA looking at me every time I prescribe a medication. It gets entered into, here in Florida, it's called eForce, but it's a prescription drug monitoring database. So I'm noted as a prescriber. The patient is noted as being on this controlled substance. If they've also been on an opiate in the past, if they've been on a benzo in the past, if they've been on any other controlled substance in the past, that will get flagged. So it's never good practice to have two controlled substances at once, though providers will do it and they act like it's not a big deal. Because eventually the DEA catches up to you. So yeah, like the DEA isn't going to knock on my door if I have somebody who's prescribed, let's say Concerta and then let's say Xanax because they can't sleep, right? I wouldn't do that, but I'm saying some providers do, unfortunately. But that will definitely gets flagged. And you can continue doing that. The DA is not going to knock on my door today, but if that becomes a pattern of prescribing, eventually they will, and it becomes alerted, and because injuries can happen. The other thing is the other issue, I would say. So number one is the drug monitoring. There's a lot of eyeballs on providers who are prescribing medications. Then you've got number two, the pharmacies. So now the pharmacies have been cracked down on as well. And so with COVID, a lot of things were laxed where anyone can go to a telehealth provider and get a prescription for, say, Adderall. Oh, I have all these symptoms and read off of a list, not do any psychological testing. And there are certain tests you can do in office that can help you really determine if you truly have ADHD or if the person is just reading off a list of symptoms. But so that exacerbated it. People just reading off a list of symptoms to providers via telehealth, they get their Adderall. That created a shortage. Now the pandemic emergency is over. DEA regulations are coming back and being enforced, which requires at least one face-to-face visit for someone that's being prescribed a controlled substance. So that is considered a barrier now because everyone got so used to the telehealth model and being able to quickly access these types of medications. So as a provider looking at that, you've got to consider all of these factors and be very cautious when prescribing any type of controlled substance, whether it is a stimulant or otherwise, because of those risks. And then, of course, when you do get a patient who needs to be on a medication like a stimulant for ADHD to help them with their struggles of focus and lack of concentration and work and things like that at school. You want to make sure that the diagnosis is correct. Some providers will go the route of doing a urinary drug test to make sure that, hey, that this person isn't abusing other drugs. Like maybe they have, because some people can hide it really well. So yeah, you may have to jump through hoops, and there may be stigma associated with it. But the reason being is multifactorial, because of the fact that we have a lot of people who are abusing the drug, which creates, an issue overall. And then we have this crisis of addiction with opiates that makes more scrutiny on the prescribing of controlled substances for the provider. And then now the regulations of the DEA, pharmacies are now questioning the prescriptions themselves. So even if I prescribe a medication like, say, Adderall for a patient who really needs it for their ADHD symptoms, and we tried all of the things, then that pharmacy, it's becoming less now, I guess, but that pharmacy usually will call the office and say, was this person seen in the office? To make sure that they were seen in person to get the prescription. And if not, they won't um, fill it. So it's becoming, it has become more of an issue. So it is unfortunate. I'm glad you're bringing it up, and it is frustrating. It's frustrating for the provider as much as it's frustrating for the patient who really needs the medication. And I'm really not sure what the answer is, to help resolve that. But unfortunately, the stimulants are very addictive. And insulin isn't addictive. You don't have people out there on the streets craving insulin. So yeah, I see where you're coming from with that, but that comparison is a little, maybe a little bit of hyperbole there, but really it's, it is a shame. It is a shame that, that is happening. Lulu Love, hi. I'm finding I can't even work with my therapist because of my diagnosis of BPD. That's borderline personality disorder, for those who don't know. I am pushing him away as other people, doing impulsive things, fear of abandonment, and struggling with relationships. Yeah, that's unfortunate. And that unfortunately happens with BPD. But the fact that you're recognizing it is a good thing. The primary had suggested Lamictal, surprised because he is integrative and I don't want more psych meds. Can you discuss borderline? Yeah, so medications for borderline personality disorder, because borderline personality disorder is a personality disorder, and therapy is the way to treat that, dialectical behavior therapy. But there is a challenge there, especially if someone's been borderline for a long time and now trying to address it. That's ingrained in that personality. There aren't any medications that are approved to treat borderline. So providers will often resort to, hey, let's use mood stabilizers to help stabilize some of the mood, or which is what lamotrigine is, or even antipsychotics at low doses, which are being used as mood stabilizers for patients with borderline. So not that they have bipolar or they have that type of diagnosis. It's just to treat the mood symptoms, the mood fluctuations, the irritability. Unfortunately, what happens with these patients is you're trying to treat something that that really is something that the person has to work on themselves to understand how to control their emotions and understands how to recognize their emotions. And then that person has to do a lot of the work. What happens when we start the path of treating someone with borderline with meds is that maybe it can be effective at first, but then when they start becoming emotionally out of control again, because they're resulting to previous coping mechanisms, then they want more and more of the medication when it's not the medication. And then you can end up polypharmacy and going down that path very, very quickly. So medication can be leveraged sometimes successfully for people who are willing to really put in the work to do the dialectical behavior therapy. What I have to say in your case is that the fact that you're recognizing it is a good thing. And I would talk to your therapist about that. Like, hey, I recognize I'm pushing you away. I recognize I'm pushing a lot of my providers away. I recognize this is a part of my BPD, but I really need help with this. Let's work on doing some maybe mindfulness. Let's work on understanding, where these emotions are coming from. I really want to work on this because it sounds to me like that's where you're at. And not easy when 22 years of benzos and severe chronic pain. Yeah, so your presentation is complex. This isn't just someone with borderline. This is someone who's been on benzos for 22 years. You have severe chronic pain, which also affects mood, irritability, anxiety. So going down the route of adding psychotropic medications to treat something that can be resolved with therapy, you know, the risk versus the benefits. We have to think about those two things. Perhaps in the short term, if that can get you thinking a little more clearly or being less um, irritable and emotionally high, let's say, like in that type of state, to be able to participate in the therapy that's necessary, perhaps. But you have to then look at what is that going to look like with the benzos on board? What is that going to look like if you're on other medications on top of that? And how is that going to affect your whole clinical picture? So definitely a lot of things to think about there. But it is tricky when you're dealing with something like borderline personality, because unfortunately these patients are the ones who are the most difficult to treat in a psychopharmacology standpoint, because really when you start treat no medications really work or getting at the root of what's causing these emotional outbursts, the emotional dysregulation. And so therapy is really key there. But they're also the ones who are more resistant to therapy, and like you were pointing out, will start to split people and push people away because they have issues with abandonment. And so they feel like if they're the ones in the lead and do the splitting, they're more in control of that. So there's a lot of nuances there. But I would say if you're in therapy, that's great. Talk to your therapist about this. I think that would be the first thing to do, and see if there's something you guys can do together to work on this. But I do think that the fact that you're bringing it up and recognizing it, you're far ahead of a lot of others who have the borderline and don't even recognize that it's a problem. So I think that that's actually good, and may even be a result of the therapy that you're doing. Eric, hello. Does Lyrica really work for anxiety, and is it worth it for the side effects? Okay, Lyrica is pregabalin, so it's a GABAergic drug. Um, it can help. It's an off-label use. Is it worth it? In my opinion, no, it's not. Not only the side effects, but the risk of having to come off of it and dealing with a protracted withdrawal. If you have to come off of it quickly, or you end up coming off of it too quickly and dealing with those issues. And also the fact that some of the side effects that I see with patients who are on Lyrica and using it for anxiety, it actually can cause more depression, emotional blunting, and those types of things. So, in my opinion, it's not worth it for those side effects because it makes the clinical picture worse. Um, but have people used it? I think people have probably used it successfully for anxiety, and that's why it's being used off label. Um, but in my opinion, it's not something, that I would say it's worth the risk. Um, I would have to go case by case though, but I'm just generally speaking, when I'm looking at the clinical picture and the experiences I've had with patients on Lyrica, I would say in general, I don't think it's worth the risk of the side effects, or even the risk of getting into that dependence tolerance state where you have to come off and dealing with all of that. It is one of the medications that's in the Maudsley prescribing guides. So there's a lot of other explanation on that medication and why it's very risky. If that's something you want to look into, but definitely, in my opinion, I don't think in general it's worth it for most people. Um, Hangrier, thought on Prozac 20 milligrams and Wellbutrin 150, 300. The Prozac Wellbutrin combo, you do have to be careful with the CYP. I believe it's the CYP 2D6 with those two. So you can be on both of them. You just want to be careful because the Wellbutrin can inhibit the metabolism of the Prozac. So staying on a lower dose would be safest. On the video that I did on, it's called Well Oft. It talks about combining bupropion with SSRIs and getting that benefit of serotonin and dopamine to help with depression. So it is a common combination, using SSRIs with Wellbutrin. You just have to be careful. Make sure, I'm sure your provider is aware of this and understands that, there is a risk of serotonin syndrome if you increase this SSRI too high and those types of things. But just being aware of that, also being aware of the seizure risk of combining these two medications. And again, always looking for root causes as well, looking at the basic labs for mental health to make sure that is something that the root causes have been looked at. So we're going to take on one more question here. I believe there are many more questions remaining that we won't be able to get to, and I do have to end here. So we'll take one more question, and then the rest we're going to have newsletter. I'll answer 4 or 5 of remaining questions in a newsletter that I'll put out in the next week. So if you guys aren't already, sign up for the newsletter at levelheadedmind.com. Okay. Is it normal, MDP lady, is it normal to build tolerance to Vyvanse? I've been on 40 milligrams for a year. My provider has added Adderall 10 milligrams, and that's been working great. Yeah, it is. And that's this whole, with any medication that causes dependence, this addiction, that's part of it because you build tolerance to it. Now, in my opinion, I wouldn't be adding more stimulants to it. I would say, let's take a holiday for a little while off of the medication, and then get you back on a dose, or you could even increase the Vyvanse to 50, 60, you can go up to 70 milligrams of Vyvanse. So adding an Adderall and Vyvanse is not good standard practice. And of course, like I mentioned earlier, the DEA, boom, zooming in on that. I'm sure it's flagged, but the fact that the pharmacists are filling that surprises me too. But anyway, yes, you can build tolerance with stimulant medications, just like any other medication that causes addiction. Unfortunately, that's one of the effects. When patients are on stimulants, I always make sure to tell them, hey, this can happen. So good to take breaks Monday through Friday. If you're using it for work, take weekends off. If you're working weekends, try to do 1 weekend a month. Just give yourself a break so you don't develop the tolerance. If you end up developing tolerance and you increase dose, and now you're at 70 milligrams of Vyvanse, instead of adding more things, we would say, hey, let's start lowering the dose, or let's give you a break off of it, which you would end up crashing for a little bit to get back on it. So to avoid that uncomfortable experience of kind of detoxing your body from the medication and then restarting, I would say, taking breaks, taking holidays is key, and not using it 7 days a week. 24/7. So thank you so much, everyone, for being here. Consider being a channel member. We've got lots of videos on there. There is a video on the Wellbutrin and bupropion. I go through my outlines for some of my videos, especially the ones that are recommended by the channel members. I'll actually show you my outline, how I'm going through the process of making that video and explaining a lot of the details that you don't get from the video. Um, you get from the members live. So you kind of get like my thought process going through it and finding out like, wow, I looked at all these papers. This is what I really found interesting, kind of a thing, and kind of giving more of the details through that. And then of course you get the early access to those videos. Plus there are other videos there that aren't public, that are just for members, based off of um, feedback from members, questions from members, or just me wanting to support you guys through your mental health journey and give you some valuable tools and resources that you can use to better your mental health. That emphasizes the use of skills before pills. So I thank you all for being here today. I wish you all well on your mental health care journey. I look forward to seeing you next month in my next live, which will be November the 16th is the third Saturday. So third Saturday of each month, as long as Raul is available to help with moderating, and he says he's available, then we will be here for you on November the 16th, 11 a.m. Eastern Standard Time. I love that you come with a lot of questions. You get my thinking cap on and get me going, and I appreciate that. And I hope that it's been very helpful for you. Take care and God bless.